Are you suffering from sciatic nerve pain that runs down your leg and can't find lasting relief? If you're over 60 and still maintain this specific habit I'm going to reveal today, you may be completely sabotaging your recovery and exacerbating a condition that's already naturally more challenging in old age. As a specialist who has worked with elderly patients with sciatica for years, I witness daily how a single, seemingly harmless behavior can turn occasional pain into chronic, debilitating suffering. I'd love to hear where you're watching from today. Leave a comment below telling me where you live and if you or anyone in your family suffers from sciatic nerve pain. Your participation is crucial for me to continue creating content increasingly tailored to your specific needs. And don't forget to subscribe to the channel and turn on notifications so you don't miss any valuable tips on how to live a quality life after 60, especially when it comes to sciatic nerve pain. The sciatic nerve is the largest and longest nerve in the human body, extending from the lower back through the buttocks, thighs, and down to the feet. In people over 60, this nerve faces unique challenges due to the natural aging process. Intervertebral cartilage loses elasticity and height, ligaments become less flexible, and the muscles supporting the spine often progressively weaken. Epidemiological studies show that approximately 40% of adults will experience some episode of sciatica during their lifetime, with the incidence increasing significantly after age 50, peaking between ages 60 and 70. The anatomy of the sciatic nerve in the elderly presents particularities that make this population especially vulnerable. The nerve emerges from the spine through openings called intervertebral foramina, which naturally narrow with aging due to the development of osteophytes, ligament thickening, and disc protrusions. When we add harmful behavioral habits to these anatomical factors, we create the perfect scenario for the development of persistent and difficult-to-resolve sciatica. Recent scientific research published in the Journal of Geriatric Medicine indicates that older adults who maintain certain behavioral patterns are up to 300% more likely to develop chronic sciatica compared to those who change these habits after age 60. Most alarmingly, many healthcare professionals fail to adequately address this behavioral issue, focusing solely on palliative treatments without addressing the root cause of the problem. The habit I need to highlight today is extremely common among older adults and is directly related to the posture we adopt during the most basic daily activities. This specific behavior creates a cascade of biomechanical events that culminates in progressive compression of the sciatic nerve, being particularly devastating in individuals over 60 due to existing structural changes in the spine. When we talk about sciatica in the elderly, we cannot ignore the fact that the aging process brings with it significant changes in the biomechanics of the spine. Dehydration of the intervertebral discs, a natural phenomenon after the age of 50, results in a decrease in disc height and consequent approximation of the vertebrae. This approximation reduces the space available for the sciatic nerve as it emerges from the spine, creating a situation of anatomical vulnerability that can be drastically aggravated by poor postural habits. The musculoskeletal system of people over 60 also exhibits characteristics that exacerbate the negative effects of harmful habits. Sarcopenia, the progressive age-related loss of muscle mass, particularly affects the deep stabilizing muscles of the spine. Muscles such as the multifidus, rotators, and intertransversarii become less efficient in their function of maintaining segmental stability of the spine, transferring greater overload to passive structures such as ligaments and intervertebral discs. This transfer of overload becomes even more problematic when combined with the specific habit I'll discuss in detail in the following sections. It's important to understand that this isn't just an isolated postural issue, but rather a behavioral pattern that creates a vicious cycle of progressive deterioration in sciatic nerve function. The devastating habit that is destroying the health of your sciatic nerve after age 60 is remaining seated for prolonged periods with poor posture, especially on low chairs, recliners, or soft sofas. This seemingly harmless behavior poses one of the greatest threats to the integrity of the sciatic nerve in older adults, creating a series of biomechanical changes that culminate in progressive neural compression and chronic inflammation. When a person over 60 sits improperly for extended periods, the natural curvature of the lumbar spine dramatically changes. The physiological lordosis, the natural curve that maintains proper vertebrae alignment, becomes straightened or even inverted, creating pathological lumbar kyphosis. This postural change forces the L4, L5, and L5S1 intervertebral discs, the main origins of the sciatic nerve, to bear asymmetrical and excessive loads. In older adults, intervertebral discs already exhibit natural degeneration, with a reduction in the nucleus pulposus and fibrosis of the annulus fibrosus. When subjected to asymmetrical pressure resulting from poor sitting posture, these degenerated discs fail to evenly distribute compressive forces, concentrating pressure in specific areas. This concentration of pressure can result in disc protrusions or herniations that directly compress the nerve roots that form the sciatic nerve. Biomechanical studies using electromyography demonstrate that poor sitting posture in older adults generates an increase of up to 400% in intradiscal pressure compared to standing. This pressure increase is even more pronounced when the person sits on low or soft surfaces, which force excessive hip flexion and consequent posteriorization of the pelvis. Pelvic posteriorization eliminates the natural lumbar lordosis and creates excessive tension on the posterior structures of the spine, including ligaments, joint capsules, and nerve roots. The mechanism of injury becomes even more complex when we consider that older adults often remain in the same position for hours, whether watching television, reading, or performing manual activities. This prolonged immobility results in stiffness in the myofascial structures surrounding the lumbar spine and pelvis. Muscles such as the psoas, piriformis, and hamstrings develop adaptive shortening that perpetuates poor posture even when the person stands up. The piriformis muscle deserves special attention in this context, as its anatomical relationship with the sciatic nerve is particularly relevant in the elderly. In approximately 15% of the population, the sciatic nerve passes through the piriformis muscle, and in another 10%, a division of the nerve pierces the muscle. When the piriformis develops excessive tension due to prolonged sitting, it can directly compress the sciatic nerve, causing piriformis syndrome, a condition that mimics and can coexist with sciatica of disc origin. Neural compression resulting from poor sitting posture is not limited to mechanical aspects. When subjected to chronic compression, the sciatic nerve develops a local inflammatory process characterized by the release of chemical mediators such as prostaglandins, leukotrienes, and pro-inflammatory cytokines. This inflammatory response increases neural sensitivity and can perpetuate pain even after the initial compressive factor is removed. In older adults, the ability to resolve neural inflammation is naturally diminished due to a phenomenon known as inflammaging, a state of chronic low-grade inflammation associated with aging. This baseline inflammatory state makes the nervous system of older adults less resilient to additional injury and more prone to developing central sensitization, where the central nervous system amplifies pain signals disproportionately to peripheral stimuli. The vascularization of the sciatic nerve is also compromised by prolonged sitting in the elderly. The sciatic nerve receives blood supply through small arteries that can be compressed when the nerve is under mechanical tension. In individuals over 60 who frequently present age-related microvascular changes, this vascular compression can result in neural ischemia and subsequent axonal degeneration. Research published in the European Spine Journal shows that elderly individuals who sit for more than 6 hours a day exhibit detectable changes in sciatic nerve conduction after just 3 months. These changes include decreased motor conduction velocity and prolonged sensory response latency, early indicators of impaired neural function that may precede the development of overt clinical symptoms. The most worrying aspect of this habit is its progressive and insidious nature. Many older adults gradually develop a tolerance to the initial discomfort, progressively adapting to increasingly harmful positions. This adaptation results in permanent structural changes, including spinal deformities, irreversible muscle shortening, and the formation of scar tissue around nerve roots. The devastating consequences of this habit of sitting inappropriately for prolonged periods manifest progressively and often irreversibly in older adults, creating a vicious cycle of functional deterioration that goes far beyond simple sciatic pain. What makes this situation particularly alarming is that many healthcare professionals and patients themselves underestimate the severity of the structural changes that occur silently over months or years of exposure to this harmful behavior. When an elderly person maintains an inadequate sitting posture for extended periods, specific myofascial contractures develop, permanently altering the biomechanics of the pelvis and lumbar spine. The psoas major muscle, the main hip flexor, develops adaptive shortening, resulting in an anterior pelvic tilt when the person assumes an upright position. This anterior pelvic tilt compensates for the loss of natural lumbar lordosis, but creates a compensatory hyperlordosis that concentrates compressive forces on the L4, L5, and L5-S1 facet joints. Facet joints in the elderly already exhibit natural degenerative changes, including narrowing of the joint space, osteophyte formation, and capsular thickening. When subjected to mechanical overload resulting from postural compensations, these joints develop a chronic inflammatory process that can progress to severe facet osteoarthritis. Facet osteoarthritis not only causes local pain but also contributes to the narrowing of the spinal canal and intervertebral foramina, further compressing neural structures. The phenomenon of spinal canal stenosis is particularly relevant in this context. In elderly individuals who maintain a habit of sitting improperly, the combination of posterior disc protrusions, hypertrophy of the ligamentum flavum, and the formation of facet osteophytes results in progressive narrowing of the spinal canal. This stenosis may be asymptomatic initially, but becomes clinically significant when the canal diameter is reduced beyond a critical threshold, typically below 10 to 12 millimeters. Neurogenic claudication, a characteristic symptom of spinal stenosis, manifests as pain, numbness, and weakness in the legs that worsens with walking and improves with rest or forward flexion. In older adults who develop this pattern due to improper sitting, neurogenic claudication can drastically limit walking ability, contributing to physical deconditioning and loss of functional independence. Longitudinal studies that followed older adults for periods of 5 to 10 years show that those who maintained the habit of sitting inappropriately for more than 8 hours a day had a rate of progression to symptomatic spinal stenosis 3 times higher compared to those who modified their postural habits. Even more alarming is the fact that 65% of these individuals developed significant functional limitations that impacted their quality of life and independence. The impact on the gluteal muscles represents another critical aspect of the consequences of this habit. The gluteal muscles, particularly the gluteus maximus and medius, are crucial for pelvic stability and hip movement control. Prolonged sitting results in excessive stretching and subsequent weakening of these muscles, a phenomenon known as gluteal amnesia or dead glute syndrome. In older adults, gluteal amnesia has devastating functional consequences. Gluteal weakness alters the pattern of muscle activation during basic activities such as rising from a chair, climbing stairs, or walking. This alteration forces other muscles, including the hamstrings and lower back muscles, to take on compensatory functions for which they are not adequately prepared, resulting in overload and the eventual development of myofascial trigger points. Myofascial trigger points in muscles such as the piriformis, quadratus lumborum, and gluteus minimus can refer pain directly to the sciatic nerve, creating a pain pattern that perfectly mimics true sciatica. This overlapping symptom set makes differential diagnosis extremely challenging and can result in inappropriate treatments that fail to address the root cause. Altered proprioception represents an often overlooked but profoundly impactful consequence of this habit. Proprioception, the nervous system's ability to perceive body position and movement in space, depends on sensory information from joint, muscle, and skin receptors. Prolonged sitting in older adults results in decreased activity of these receptors, leading to proprioceptive deficits that significantly increase the risk of falls. Research published in the Journal of Geriatric Physical Therapy shows that older adults with proprioceptive deficits related to prolonged sitting have a 40% higher risk of falls compared to those with preserved proprioception. Considering that falls in older adults can result in serious fractures, prolonged hospitalization, and permanent loss of independence, the magnitude of this consequence cannot be underestimated. The cardiovascular system also suffers significant impacts from this habit. Prolonged sitting in the elderly results in decreased venous return to the lower limbs, contributing to the development of edema, varicose veins, and, in extreme cases, deep vein thrombosis. The reduction in physical activity resulting from sciatica symptoms creates a vicious cycle where cardiovascular deconditioning perpetuates exercise intolerance and limits available therapeutic options. Sleep quality is often compromised in older adults who develop chronic sciatica due to this habit. Neural pain can interfere with normal sleep cycles, resulting in fragmented REM sleep and decreased deep sleep. Sleep deprivation, in turn, increases pain sensitivity through complex neuroendocrine mechanisms, creating another vicious cycle that perpetuates the patient's suffering. The definitive solution to reversing the damage caused by this devastating habit requires a multifaceted, senior-specific approach that considers not only postural correction, but also the reversal of structural and functional adaptations that have developed over time. The protocol I will present was developed specifically for people over 60, considering the unique limitations and needs of this population, and has demonstrated exceptional results when applied consistently and progressively. The first pillar of correction is the immediate modification of the physical environment where the elderly person spends most of their time sitting. The height of the chair should be adjusted so that the hips are slightly higher than the knees, creating an angle of approximately 110 to 120 degrees at the hip joint. This position favors the maintenance of natural lumbar lordosis and significantly reduces intradiscal pressure. For elderly people who use armchairs or sofas, it is essential to add firm cushions that elevate the seat and provide adequate lumbar support. Lumbar support should be positioned precisely at the spine's natural curvature, typically at the L3-L4 level, and should be firm enough to maintain lordosis without being uncomfortable. Cushions that are too soft or poorly positioned can be counterproductive, creating inappropriate pressure points or forcing excessive hyperlordosis. The chair's backrest should be inclined at a 110 degree angle relative to the seat, allowing the elderly person to receive adequate support without sliding forward. Implementing regular postural breaks is a crucial component of the correction protocol. Older adults should be instructed to interrupt sitting every 30-45 minutes, performing specific movements to mobilize the lumbar spine and hips. During these breaks, simple exercises such as standing lumbar extension, pelvic rotation, and walking for 2 to 3 minutes can significantly reverse the negative effects of prolonged compression. The corrective exercise protocol should be initiated gradually, respecting each individual's limitations. The first goal is to restore lumbar spine mobility through controlled flexion exercises. The controlled lumbar flexion exercise, performed in a supine position with the knees bent toward the chest, should be held for 30 seconds and repeated 5 to 8 times, 2 to 3 times a day. This exercise promotes stretching of shortened paraspinal muscles and improves mobility of rigid vertebral segments. Correcting psoas muscle contracture requires special attention in the elderly, as this muscle often presents significant shortening. Psoas stretching should be performed in a standing position, with one foot in front of the other, flexing the trunk forward while keeping the back leg extended. This stretch should be held for 45-60 seconds and repeated 3 to 4 times on each side, always respecting the elderly person's comfort level. Strengthening the gluteal muscles is crucial for correcting biomechanical changes. The gluteal bridge exercise, performed in a supine position with knees bent, is particularly effective for older adults. The contraction should be held for 10-15 seconds, with 10-15 repetitions, gradually progressing to more challenging variations such as the single-leg bridge or foot elevation. This exercise not only strengthens the glutes, but also improves core stability and neuromuscular coordination. Dynamic postural re-education represents an advanced aspect of the protocol, focusing on body awareness and motor control. Proprioception exercises, such as balancing on one leg or walking in a straight line, help restore spatial perception compromised by prolonged sitting. These exercises should initially be performed with support near a wall or stable piece of furniture, gradually progressing to independent execution. Specific manual therapy can significantly accelerate the recovery process in older adults. Techniques such as passive joint mobilization of the L4, L5, and L5-S1 segments, when performed by a qualified physical therapist, can improve joint mobility and reduce neural compression. Myofascial release of the piriformis, quadratus lumborum, and hamstring muscles through direct pressure or dry needling techniques can resolve trigger points and improve muscle function. Controlling the inflammatory response through specific therapeutic modalities for the elderly includes the application of controlled cryotherapy and superficial thermotherapy. Applying ice for 15-20 minutes during acute symptom exacerbations can reduce neural inflammation, while applying moist heat for 20-30 minutes can improve muscle flexibility and promote relaxation. Elderly patients should be carefully monitored during these treatments due to the risk of thermal injury to sensitive skin. Changing daily activity patterns requires careful planning and adaptation to established routines. Seniors should be advised to alternate between different positions throughout the day, alternating periods of sitting with periods of standing or walking. Activities such as watching television can be performed partially standing using a high table or countertop for support. Reading can be done in a reclining position with adequate support, avoiding excessive cervical flexion. Monitoring signs of improvement is essential to adjust the protocol as needed. Positive indicators include decreased pain intensity, improved sitting tolerance, increased lumbar range of motion, and reduced morning stiffness. Older adults should be instructed to document this progress using simple pain scales and specific functional questionnaires. Education about warning signs is crucial, especially considering that older adults may have other comorbidities that complicate their clinical picture. Symptoms such as progressive weakness of the lower limbs, changes in sphincter control, or intense nighttime pain that disrupts sleep should prompt immediate medical evaluation, as they may indicate severe neural compression or other conditions requiring specialized intervention. Final considerations regarding this devastating habit that is harming millions of elderly Brazilians require a careful and individualized approach, especially since each person over 60 has unique characteristics in terms of physical fitness, associated comorbidities, and degree of existing impairment. It is crucial to understand that reversing the damage caused by prolonged poor sitting posture does not happen overnight, but rather through a gradual and consistent process that can take 3 to 6 months to show significant results. The success of the correction protocol depends fundamentally on the consistency in applying postural modifications and corrective exercises. Seniors should be guided to implement changes progressively, starting with simple changes such as adjusting chair height and implementing regular postural breaks, gradually progressing to more specific exercises according to individual tolerance and capacity. It is important to set realistic goals and celebrate small progress, as motivation is crucial for long-term treatment adherence. Family integration is an often underestimated but absolutely essential aspect of therapeutic success. Family members should be educated about the importance of postural modifications and encouraged to support the elderly individual in implementing the necessary changes. This can range from reorganizing the home environment to accompanying them with daily exercise, creating a support system that facilitates the maintenance of new healthy habits. Regular medical monitoring becomes even more important during the correction process, especially for older adults with other health conditions such as diabetes, hypertension, or osteoporosis. These comorbidities can influence both the progression of sciatica and the response to treatment, requiring specific adjustments to the therapeutic protocol. Constant communication between the older adult, family members, and healthcare team ensures that any changes in the clinical condition are promptly identified and addressed. There are specific contraindications and precautions that must be strictly observed during the implementation of the correction protocol. Elderly individuals with a history of vertebral compression fractures, unstable spondylolisthesis, or spinal tumors should have their exercises carefully supervised by qualified professionals. Excessive lumbar extension movements may be contraindicated in cases of severe spinal stenosis, while flexion exercises may aggravate large disc herniations. Osteoporosis, an extremely common condition in older adults, especially postmenopausal women, requires specific modifications to exercise protocols. Movements that involve excessive anterior flexion of the spine should be avoided or performed with extreme caution, as they can precipitate vertebral compression fractures. Strengthening exercises should begin with very low loads and progress slowly, always prioritizing quality of movement over quantity or intensity. Elderly patients taking oral anticoagulants, a common medication for preventing cardiovascular events, should be especially cautious with manual therapy modalities that involve deep pressure or joint manipulation. The risk of bruising or bleeding should always be considered, opting for gentler, supervised techniques when necessary. Coordination with the treating physician is essential to determine the safety of different therapeutic approaches. The use of non-steroidal anti-inflammatory drugs, while potentially providing temporary pain relief, should be carefully monitored in the elderly due to the increased risk of gastrointestinal, renal, and cardiovascular adverse effects. When possible, non-pharmacological methods of pain control should be prioritized, using medications only as adjuvants during acute exacerbations and under close medical supervision. Warning signs that require immediate medical evaluation include sudden development of significant motor weakness in the lower limbs, loss of sphincter control, rapidly progressive tingling or numbness, or pain that worsens dramatically despite proper implementation of the correction protocol. These symptoms may indicate severe neural compression that requires urgent specialized intervention, possibly including surgical procedures. Cauda equina syndrome is a neurological emergency that, although rare, can occur in elderly patients with severe spinal stenosis. Symptoms include severe low back pain, bilateral lower limb weakness, saddle anesthesia, and sphincter dysfunction. Any combination of these symptoms requires emergency neurosurgical evaluation, as delayed treatment can result in permanent neurological sequelae. The implementation protocol should begin immediately after identifying the harmful habit, but always respecting individual limitations. The first week should focus exclusively on modifying the physical environment and implementing postural breaks, allowing the elderly person to gradually adapt to the changes. The second and third weeks can introduce basic mobilization exercises, while strengthening exercises should only be incorporated after the fourth week, once tolerance and adherence have been established. Professional supervision is highly recommended, especially in the early stages of protocol implementation. A physical therapist specializing in geriatrics can customize exercises to specific needs, monitor proper execution, and make adjustments as needed. The ideal frequency of professional supervision ranges from 1-2 weekly sessions for the first 4-6 weeks, progressing to bi-weekly or monthly sessions as the patient's independence increases. If this video was helpful to you or an elderly person in your family suffering from sciatic nerve pain, please click the like button so this content reaches more people who urgently need this information. Many seniors are suffering unnecessarily simply because they don't realize that such a common habit could be the root of their problems. Leave a detailed comment sharing your experience with sciatic nerve pain or the experience of an elderly family member. Share with us how long you've lived with this pain, what treatments you've tried, and whether you've identified with the habit I discussed today. Your feedback is crucial for me to create increasingly targeted and useful content for our community of active and healthy seniors. Subscribe to the channel and turn on notifications so you don't miss any valuable tips on health and quality of life after 60. I've prepared a special series on sciatic nerve in older adults, covering everything from specific exercises to nutritional guidelines that can enhance recovery. Share this video with someone who also suffers from sciatica or knows an older adult. This information can literally transform the quality of life of someone you love, offering hope and practical solutions to a problem many consider inevitable with aging. And tell us in the comments what topic about the sciatic nerve you'd like to see in the next video. Would you like to learn specific exercises to strengthen the muscles that protect the sciatic nerve? Or would you prefer to learn about anti-inflammatory foods that can speed recovery? Perhaps tips on how to organize your home to make it more sciatica-friendly? Your opinion guides the content I produce, so please participate actively in this community dedicated to healthy and active aging. Remember, aging doesn't mean accepting pain as inevitable. With adequate knowledge and the right actions, it's possible to live with quality, mobility, and freedom even after 60, 70, or 80. You deserve to live each day with as much comfort and independence as possible,